a combination of upper motor and lower motor neuron signs, it will be amyotrophic lateral sclerosis. These are patients nga may weakness at the same time may spasticity man. If it's a purely lower motor neuron nga disease, then it can be exemplified by progressive muscular atrophy involving the limbs or progressive bulbar palsy involving the bulbar muscles, no? Involving the corticobulbar fibers. Kung purely upper motor neuron disease naman, then it's exemplified by progressive lateral sclerosis involving the lateral aspect of the spinal cord, the corticospinal tracts of the spinal cord involving the limbs, and progressive pseudobulbar palsy involving the bulbar muscles. So degenerative siya. There's loss of motor neurons, and it's a combination of upper and lower motor neuron na signs and symptoms. It was discovered by a French neurologist, Dr. Jean-Martin Charcot, by more than 100 years ago in 1869. Um, he described it as a progressive neurodegenerative disease that affects neurons of the brain and the spinal cord, wherein the brain loses ability to initiate and control muscle movement. So when we talk about pure ALS lang, it means that there is degeneration and loss of motor neurons in the spinal cord, the brain, and the brainstem, resulting in a variety of upper motor neuron, lower motor neuron signs and symptoms. Sometimes there are interchangeable words. In the UK, it's called motor neuron disease. In Europe and North America, or in the United States, it's called amyotrophic lateral sclerosis, or it can also be called Charcot's disease, no? There was a time that it was popularly called Lou Gehrig's disease. Kasi Lou Gehrig was a team captain of the New York Yankee baseball team. So actually he was diagnosed to have ALS at a very young age. He was in the middle of the series. So he was playing at the age of 35. He had developed symptoms of generalized weakness. Tapos the following year, he was diagnosed at 36 years old to have amyotrophic lateral sclerosis. And then he succumbed to death at age 37. So very, very young um, when he passed away. Of course, these patients hindi man common ang mga autonomic dysfunction, ang mga involvement of the heart, the lungs, the kidneys. So more likely these patients will exit because of complications, no, mga respiratory complications like that. Okay, for the incidence, it's about 4 to 10 per 100,000. It used to be mga 2 per 100,000. It becomes higher now. Males will slightly have higher incidence than females of 1.7 is to 1 ratio. So the peak onset will be at the mid 50s, but it can range from 20 years old to 90 years old. There should be no racial predilection, but in these countries, in these areas, there seems to be higher incidence of reported cases, like in Guam, no? So in fact, there's a complex that is very common in Guam, what we call the ALS Parkinson's dementia complex of Guam. So that's it. And then in the Western New Guinea, in the Key Peninsula in Japan. 95% of the time, it's sporadic, and then 5% will have autosomal dominant transmission. Okay, so what are these upper motor neuron signs and symptoms um, included? So there's loss of dexterity, there's slowing of movement, there's loss of muscle strength or weakness, there is stiffness or spasticity, and there's emotional ability. So pati ang behaviors ng patient will be affected, no? Remember, the one in Guam, it's a combination of ALS and dementia and Parkinson's, no? So meaning ang spectrum of this illness can also include behavioral changes. Okay, so how do we test for these upper motor neuron signs? For the cervical aspect, because nerves coming out from the cervical area, will innervate the upper extremity. So we check for pathologic DTRs of the upper extremity, and we do the Hoffman's test for spasticity. Are you familiar with the Hoffman's test? Anybody? Anybody who knows about the Hoffman's test? Ang Hoffman's, hello, do you hear me?
Yes, Doc.
Okay. Ang Hoffman's spasticity is a test nga daw similar to Babinski but for the upper extremity, no? So it's done by flicking the middle finger downward into flexion. And what will happen? The examiner does this. So if flick ya downward like that, do you see it? If flick niya downward, and then the positive test will be flexion of the thumb and then the index finger. So flick it downward, and then there will be flexion of the thumb and the index finger. So as the examiner does this like that, that's positive Hoffman's. So it will mean corticospinal tract involvement for the upper extremity. And for the bulbar test, these are what we call frontal release signs, meaning this will mean damage to the corticobulbar fibers and might reflect involvement of the frontal lobe, no? So there's jaw jerk. Do you know of jaw jerk? How to do, or were you taught how to do jaw jerk?
No, Doc. Hindi familiar.
Ang jaw jerk, you tap the chin of the patient, no? When you tap it with a neurohammer, when you tap it with a neurohammer, there will be contraction of the muscles for mastication, the masseter, the temporalis, the medial pterygoids. So there will be closure of the jaw of the patient. Another is the snout reflex. So when snout reflex is done by making the patient close his lips and then stroke this portion here, when you stroke it here, the patient will do a pouting of his lips like that. So that's a positive snout reflex. Palmomental reflex will be stroking the palm of the patient. So when you stroke it like this or when you stroke it like that, there will be contraction of the mentalis muscle. So that's the palmomental reflex. There's the pseudobulbar affect or pseudobulbar palsy, and then the glabellar reflex, you tap it here in the forehead. So ang glabella is the space here between two eyebrows. So you tap it here. Supposedly, ang normal response will be contraction of the orbicularis oculi muscle. Pero kung may damage of the fibers there, then there will be Meyerson sign. Maklo siya, sige-sige, there will be continuous, persistent contraction of the orbicularis oculi such that the eye will not open, the eyes will not open anymore uh, for a while. Okay, so these are signs to test for the bulbar function of the patient. So put a finger here and then tap it with a neurohammer and there will be closure of the jaw. Palmomental, you stroke the palmar area of the hand and there will be contraction of the mentalis muscle. Okay, so for the thoracic nerves, we do the abdominal reflex na testing. 'Di ba when you stroke it to the umbilicus should be going towards the direction of the stimulation. And for the lumbosacral area, we test for the reflexes of the lower extremities and we check for Babinski signs, no? Of whatever tests you would want to perform, whether Babinski or Oppenheim test or the Schiffer's test, the Shaddak's test, um, you can do that and then test for spasticity as well. Okay, so that's about for the upper motor neuron signs. What about for the lower motor neuron? there will be loss of muscle strength, no? So weakness man. So either the upper or the lower motor neuron niya sign will have weakness as presentation. There will be denervation atrophy, and there will be fasciculations. What is the difference of fibrillation and fasciculation? Do you know? Anong what do you think is the difference of fasciculation and fibrillation?
Fasciculation, Dok, visible na ano, contraction. And then
Mm-mm.
ang fibrillations naman niya, muscle twitches man siya, Dok, pero hindi siya visible.
Yes, so sometimes only the patient feels of the movement in fibrillation, or sometimes you will only see of it during testing. Fasciculations, that's correct, no? Nga, these are visible or obvious na muscle twitches or spontaneous muscle movement. So one of the areas that we check for fasciculations are tongue fasciculations. We can see here there's atrophy of the tongue, but supposedly if this is moving, there can be movement of the spontaneous movement of the tongue or tongue fasciculation. And there are muscle cramps as well. Okay, so for the common signs and symptoms at initial presentation, it's weakness for about 63%. They're the bulbar signs that we have mentioned earlier. There's atrophy of the muscles, pain and cramps or muscle cramps. There to about 3.5% of patients, there are fasciculations and paresthesias. Paresthesias, these are tingling sensations, no? So we say nga hindi man gid tani affected ang sensory nerves, but to some extent there can be incidents of paresthesias. There is weight loss when the patient reaches a point of difficulty swallowing. Maybe there's component of depression, wala na sila kakaon so much. And there is spasticity, 1.3%. With regards to weakness, ang location naman of weakness, 19.8% happens in or involves both lower extremities. So paraparesis, and then it can involve one leg at 11.9%, one arm 10.7%, either both arms or generalized weakness 8.5% and 3.8% for one side of the body. This was presented by Gubal et al. In 1985. So I've had a patient before, siya naman niya paraparesis, no? She demonstrated to me she couldn't get up in the clinic. And then there was another patient initially diagnosed to have stroke. But then imaging did not show anything until um, it was proven that she had amyotrophic lateral sclerosis. So it can really vary from one patient to another. Okay, so there can be inconsistent clinical features, not too common features, but still we can see it on the patient. Sensory dysfunction, bowel and bladder dysfunction, autonomic dysfunction, visual pathway abnormalities. There can be visual disorders, cognitive abnormalities, and bed sores. If the in the advanced stage where the patient will be lying on bed, then she will be prone to development of these pressure ulcers. This is a picture of the pathogenesis of amyotrophic lateral sclerosis. So this is the motor neuron, and or this the neuron, and then this is the effector organ, the muscle. So I will leave this as an assignment to you. Please read on what happens or what is the role of superoxide dismutase 1 um, in the coming or about of ALS. What about activated microglia, activated astrocyte? What is the role of excitotoxicity? What is the role of decreased amino acid transporter 2 in the central nervous system? We will discuss that in the next meeting. Okay, so these are the common areas affected by ALS. Let us include pre-central gyrus atrophy. So, anterior to the central gyrus is the frontal lobe, and it can be affected extensively. So meaning there can be involvement of the precentral gyrus, so meaning the motor area. That's why there will be weakness, but it can go farther anteriorly to involve the frontal eye field, to involve the association areas, including involving the frontobasal or the orbitofrontal areas. So what is there in the frontobasal or the orbitofrontal areas, Gani, at the base of the brain? What is the function of that area? 'Di ba we have mentioned before about disinhibition, social graces, jocular, no? Mga amo na, akinetic mutism, like that. So meaning, to some extent, these patients will also present with behavioral changes. That's why it was mentioned earlier na there's emotional ability on these patients, no? Kung extensive ang damage involving the orbitofrontal area. Are you there?
Yes, Doc.
Okay. So there is sparing of the Onuf's nucleus. Onuf's nucleus provides innervation to muscles of the pelvic floor or pelvic floor muscle. So it's spared, no? That's why sometimes we don't really see bowel and bladder dysfunction because of the sparing of the Onuf's nucleus or nucleus of Onuf. Although it cannot be totally absolute. May mga patients gyapon that who will complain of bowel and bladder dysfunction. Neuronal loss of cranial nerve nuclei, and there's also degeneration of the corticospinal tract. And on histopath, there's chromatin dissolution, atrophy and shrinkage, and cell loss and gliosis. On histopath, these are the findings that we see for patients with ALS. There are the Bunina bodies. Bunina bodies are intracytoplasmic eosinophilic dense granular inclusions here. There are also the Hirano bodies. These are rod-shaped intracellular aggregates that contain parallel actin filaments. And these are seen in patients in Guam, no? Those diagnosed with ALS, Parkinson's dementia complex. So there are also Lewy bodies. These are intracytoplasmic inclusions of alpha-synuclein proteins, and there are the neuritic plaques and neurofibrillary tangle. Where have you heard of Lewy bodies? Ano ganing nga disease nga on histopath there are Lewy bodies or in brain biopsy?
Parkinson's, Doc.
PC,
Parkinson Parkinson's disease will have Lewy bodies, Parkinson's with dementia, no? Amo na siyang may Lewy bodies. What about neuritic plaques, neurofibrillary tangles? Where do you see them?
MS.
We see them in dementia. Alzheimer's disease, there will be neuritic plaques and neurofibrillary tangles. So degenerative disorders, we can see combination of these abnormal inclusions. Okay, so these are Lewy bodies, that round structure there. These are the plaques, no? Neuritic plaques and neurofibrillary tangle. So it can also be seen in ALS. Okay, so there was the sporadic ALS, nagwa lang siya, and there's the familiar ALS man. It has autosomal dominant inheritance of variable penetrance. This time, the male will have equal incidence with females. It can happen at a younger onset and higher incidence of cognitive changes. So these are the types nga naga-involve sang behavior of the patient, most probably the orbitofrontal area. It will also present with chorea. So on histopath, there will be spongiform changes, plaques, and tangles, but there will be 15-year survival. Okay, supposedly it's shorter mo, mga 5 to 10 years lang survival sang ALS, but in familial ALS, it can be longer, 15-year survival. Usually, it involves chromosome 21, and 20% of the time, will have superoxide dismutase 1 mutation. No? So for this variant, 20% of them is because of the superoxide dismutase 1 enzyme. And with regards to weakness, ang presentation will be weakness of both lower extremities, more than hemiparetic na presentation or one limb, weakness of both lower extremities. Okay, so how do we diagnose ALS, or when do we suspect ALS? There are lower motor neuron signs that we see clinically or by electrophysiologic testing, ang EMG and CV, or neuropathological examination. There are also upper motor neuron signs by clinical exam, so the ones we have mentioned earlier, and there's the progression of the disease within a region or to other regions by clinical exam or history. There should be absence of other diseases to explain for the upper motor neuron or lower motor neuron signs. For all we know, that might be stroke, no, or multiple stroke. So we will have to rule out for these things. And there are no other evidences of other diseases by imaging or electrophysiologic studies. So we will have to rule out Parkinson's alone, um, these things. We will also review of these exposure to lead, mercury, and aluminum, metabolic diseases like hyperthyroidism, hyperparathyroidism, hypoglycemia, enzyme deficiency like hexasaminidase A deficiency, paraneoplastic, or cancer-related illnesses like lymphoma, small cell lung CA, and cervical spondylosis of the um, structure of the cervical spine, including paraproteinemias or bone marrow diseases. Other neurologic diseases, we will have to rule out Creutzfeldt-Jakob disease, spinocerebellar atrophy or degeneration, post-polio or polio. We will be taking up. We will be taking this up when we reach anterior horn cell diseases, Lyme's disease, and vitamin B12 deficiency. Okay, so what tests can we administer or what tests can we request to check for ALS? Creatine kinase level is typically normal, but it may be increased in 2 to 3 times normal in half of the patients. CSF might not be so reliable because it will only show mild protein deviation. All the other labs are normal. So we request for electrophysiologic test or electrodiagnostic testing or EMG and CV because it tests for nerve conduction, for sensory nerves and motor nerves. So for the sensory nerve action potential, they are normal. No, especially early in the disease, you will not detect any abnormal change. Pero for the compound motor unit action potential, it may be normal or it may show decreased amplitude, wherein the nerve conduction velocity is less than 80% of the lower limit of normal. The distal latency will be more than 1.5% of normal, and the F response more than 1.3 times of normal. So there are fibrillations and fasciculations in two muscles, in three extremities, wherein the head and then the paraspinal area is taken as one extremity already. Okay, so for the prognosis na, what do we explain to the patient? No, how long will the patient survive? Well, ang age at the time of diagnosis will be the strongest relationship to prognosis, will be your guide. Kung young pa gani ang patient, then she will have a longer or, yes, longer survival rate or better 5-year survival rate. Pero kung older ang patient, smaller na lang or shorter ang survival rate. So in patients 35 to 40 years old, they will have better 5-year survival rate versus older patients. But for Lou Gehrig, 3 years lang siya, no? At 37 years old, he passed away. 50% of the patients might be dead in 3 years, 20% um, might still live up to 5 years, and 10% might be able to survive in 10 years. So those patients who will have worse prognosis are those with bulbar onset. Kaya ti kun affected ng imo nga muscles for swallowing, maybe ang imo nga muscles for respiration, pagid ang upper respiratory tract mo dira. Then feeding will be compromised, respiration will be compromised. You will be put on, or NGT will be placed on you, and or gastrostomy or PEG, no? You will be malnourished, nutrition will be compromised until nga infections can easily catch up, or you will succumb to these infections. It also gives a worse prognosis when there is simultaneous arm and leg involvement, so generalized nga involvement. So with regard to the age, kung less than 40 years old, it can be as long as 8.2 years duration. Pero older, 61 to 70 years old, 2.6 years duration na lang. It will also have worse prognosis kung ang patient will have executive dementia, no? So the frontal lobe will be involved. If the patient will have bulbar signs, then there will be poorer prognosis as well. Or if there will be involvement of the respiratory muscles, then there will be poorer prognosis as well. Okay, that was my last slide. So, this will be my take-home assignment for you. In the next meeting, we will be talking about the different etiologies of ALS. No, so how does superoxide dismutase one bring about ALS or theorized to be contributing to ALS? So we will describe what are the presentations or what is the presentation of patients, the lower motor neuron signs of ALS patients, upper motor neuron signs, and the bulbar signs, and the diagnostic criteria of ALS. Okay, that's it. Do you have questions?
None, Doc.
Okay, so if no questions, I will
Doc,
see.
Doc,
Yes,
excuse me. Ang
yes.
take home, Doc, saan na ipas, Doc, sa next meeting?
Actually, we will discuss of it sa next meeting, no? No need to pass.
Okay.
We will just discuss of it sa next meeting. I would just want you to read it. Maybe I will ask questions and you will be the ones to answer.
Okay,
Okay?
sige. Thank you,
Sige.
Doc.
So, I think you will be the first class that I will have on Friday, no? If